I'm Ann Murphy from the Society for Translational Oncology. It gives me great pleasure today to welcome everyone to our virtual roundtable. This virtual roundtable is provided by the Society of Translational Oncology and by Einstein Montefiore. We are so pleased to welcome our expert panelists from UNC Lineberger Comprehensive Cancer Center and from UNC Healthcare. Now it gives me great pleasure to introduce Amy DePue as the moderator of this virtual roundtable. Amy is an oncology nurse navigator at UNC in the Breast Oncology Division. She's been a navigator for more than 10 years, and she has been a huge part of helping patients and families connect to better healthcare as they navigate the system. Amy, I am so happy to turn this over to you to introduce the other four panelists. Thank you.
Thank you, Ann. Joining us today, we have a great panel starting with Dr. Trevor Jolly. Dr. Jolly has been with UNC Healthcare and Lineberger Cancer Center for a number of years, having done his fellowship here. He works with the breast group and has an avid and wonderful geriatric oncology background that is very important to us as that is another group of folks that really need the extra special care. Dr. Jolly is going to be joined by Dr. Jacquelyne Gaddy, who is a third-year fellow and has been doing a lot of research in the areas of disparities. We also have Benyam Muluneh, who is a pharmacist, PharmD actually, and is also an assistant professor at the Eshelman School of Pharmacy at UNC. We are really excited because Benyam has also participated in a lot of research on the disparities that we are going to be talking about today. Also joining us is Julia Rodriguez O'Donnell, who is one of our wonderful social workers at UNC Healthcare Cancer Center. And Julia is one of the diamonds that we have discovered. She is extremely patient-oriented. She is one of the reasons why we can successfully care for our patients in North Carolina and from other areas as well. So welcome to the panel, and thank you all participants for joining us today.
In our live webinar, attendees were asked to think about the term health equity and to share what came to mind. They said, everyone getting the same level of care, accessibility for all the population, access, uptake, and outcomes. Julia is going to provide us with some context and foundation around health equity.
We wanted to start by defining what racial disparities and inequalities in healthcare are. And what we know is that although the cancer incidence and mortality overall are declining in all population groups in the United States, certain groups continue to be at increased risk of developing and dying from particular cancers. And research suggests that cancer disparities are driven by a combination of inequalities within the healthcare system and also outside the healthcare system. And according to the Centers for Disease Control and Prevention, health equity is achieved when every person has the opportunity to attain his or her full potential and no one is disadvantaged from achieving this because of racially determined characteristics or social position or any other characteristic related to that. And we also know that institutional racism causes chronic stress, conscious or unconscious bias from healthcare providers, and mistrust of the healthcare system, as well as fatalistic attitudes towards cancer by our patients and families. The COVID-19 pandemic and the simultaneous increased focus on structural racism and racial ethnic disparities across the United States have shed a lot of light on the glaring inequalities in the healthcare system, and in particularly in oncology. And wanted to share a thought-provoking statement from a physician at Colorado University Cancer Center, and that is Dr. Sana Karam, who reminds us that we're talking about a manageable and sometimes curable disease that when people are able to get the treatment they need, this can be managed, this can be eradicated with a lot of certainty. The problem isn't in biological differences between races, but in access to equitable services and treatment. And so when Black patients get the treatment equitably, they do just as well as other racial groups. So what does the data tell us? According to NCI's Surveillance, Epidemiology, and End Results program, we know that Black and African Americans have higher death rates than all other racial ethnic groups for many, although not all cancer types. Despite having similar rates of breast cancer, Black and African American women are more likely than white women to die of the disease. We know that although deaths from prostate cancer have dropped substantially in recent decades among all men, Black and African American men are twice as likely as white men to die of prostate cancer, and they continue to have the highest prostate cancer mortality among all US population groups. Hispanic, Latino, and Black African American women have higher rates of cervical cancer than women of other racial and ethnic groups, with Black African American women having the highest rates of death from the disease. Now, notably, the biggest racial survival gaps tend to be associated with cancers for which standard treatments most improve patients' prognoses, suggesting that better care might have made a difference. And a recurring theme is that Black patients are less likely than whites to receive the recommended treatments. So reducing or eliminating some cancer disparities in the pursuit of health equity will really require policy changes to overcome systemic, social, racial, and other institutional inequities. And all members of the oncology community, we all have an ethical responsibility to take steps to address these inequities in our clinical and academic and research work.
We want to bring forward a case study that brings out a few of the questions that happens. So we're going to be referring to Sam. Sam is a 53-year-old Black male who has 2 teenage children living at home. He is married. His wife does not work because she has a very severe and advanced stage of diabetes. She is on insulin. So that is something that Sam feels very responsible for making sure takes place in their home. Sam works 6 days a week, and as he tries to provide for his family. His employer has a small bit of health insurance that he offers to Sam that comes out of Sam's check. But what doesn't appear to be readily available for Sam if he were to get sick is any kind of FMLA or short-term disability. That's something that he is unsure of, and he doesn't even know where to start to ask that question. Unfortunately, Sam was having some really severe bouts of constipation that resulted in even more severe bouts of diarrhea. It's starting to show bloody diarrhea, and he is losing weight and just doesn't feel good. So he does go to see his primary care doctor, who runs tests, asks some questions, and then says, Sam, I think we need to go see a specialist. And he tells Sam that we're going to send him over to the cancer center and do some diagnostic workup. Well, you can imagine, with all of the other things on Sam's plate, this is not exactly great news, but he knows he has insurance, so he's going to go ahead. He sets up the appointments, but he's really nervous because this is going to make him take time off, which means he may or may not get paid. It means that if all of these things come to fruition, what do we do about his wife's insulin? What are some of the things? How is this going to affect his teenage kids? We're going to explore some of these things, and we're going to, as we move through, we're going to be referring back to Sam. And remember, as we discuss, what our primary themes are here. This is a very, as I said, timely conversation that we want to have, and we want to follow these 4 points. Equity and access to care, overcoming the adverse effects of structural racism in treatment, identifying and addressing health barriers. And this one that I think is extremely important from every single panelist here, open communication, especially as it relates to treatment options and immune-related adverse events. And by that, we are talking about what happens sometimes when we don't have good communication, and these adverse events do reflect on the ability to access good care. Our first question is for Dr. Jolly and Dr. Gaddy. How does a lack of representation of Black patients directly impact clinical trials and treatment developments?
Clinical trials really are used to develop the standard of care oncologic treatments that we offer to our patients. And all current therapies that are FDA approved in the US actually go through the clinical trial process. Fortunately, clinical trial data, or unfortunately, clinical trial data should really only apply to the populations that were studied. So for example, if an intervention is studied in a predominantly white population, the results of the study can really only be used in that population and should not be extrapolated to other populations, other perhaps less diverse populations. And doing so, extrapolating that data can result in a few things. So one is the population that you apply the data to may not benefit from these novel therapeutics. So if you say, for example, develop a drug in one population and apply it to another population where it was not studied, that population may not derive benefit. Secondly, you may uncover new toxicities that were not identified in the original trial. And third, I think, and importantly, these trials are used for regulatory approval of these therapeutics. And what tends to happen is that these drugs or interventions are, excuse me, approved in particular subgroups. And then once the drugs get approved, then they're applied kind of to the general population in which they are inadequately studied, or they're applied in less diverse populations where they have not been studied. And I think that you have shown some of that data. For example, Julia mentioned the data in like prostate cancer. There's also some data in multiple myeloma, where when we look at some of these studies that were done, the majority of these studies do not include large populations of the people who actually get the disease. And I think that is really troubling. Secondly, clinical trials are really a way for our patients to get access to novel therapeutics that they otherwise would not have the ability to access. So I tell my patients all the time, I can't prescribe some of these drugs for you. For example, when immunotherapies came out, when they were going through the clinical trial process, we couldn't prescribe them. But there actually are patients who are still on those clinical trials who are deriving benefits from these novel therapeutics that if they had not had the opportunity to go on those trials, would not have access to life-saving drugs. And so I think it's important to be able to offer all patients the opportunity to access these novel therapeutics without barriers, because I personally believe, and there are some studies looking at this, that clinical trials actually may improve outcomes for our patients, and not having Black and Brown patients access those trials really just kind of perpetuates the inequities in the healthcare system. Dr. Gaddy has anything to add to that?
Of course. I think one of the things that we should consider when trying to decide what is the benefit of including Black patients in clinical trials is, why is there such an overt disparity?
Right.
As Dr. Jolly said, a lot of these trials do not represent the patients that are actually impacted by the disease itself. I would be remiss if I did not mention the Buffalo 10. I'm from Buffalo. That happened in my neighborhood. And the reason I bring that up and see the relevance is because it shows just the overt structural racism. That supermarket was in a food desert. So when we think about things as far as structural racism, implicit bias, things that impact physicians from actually enrolling their patients, is just lack of rapport, not having the relationship with your patient to understand, well, how do I address this with them in a way that is sensitive and I'm able to address cultural barriers and allow this patient to know that this is done in a safe manner, as opposed to many patients, they think back to, well, I think about Tuskegee syphilis, or I think about Miss Henrietta Lacks. Those are things that patients don't forget those. You know, my grandmother thinks about those, my parents, et cetera. So I think it's really important in the early times of getting to know your patient. It's not just, okay, this patient has cancer, these are the chemotherapeutic agents I'm going to use. It's much bigger than that. And I think that's the first step in actually getting our patients enrolled in clinical trials in more of an equitable way.
Right.
I'll just add to that. You know, we tend to frame this like there is a lack of trust. I think Dr. Gaddy alluded to that just now, for example, with the Tuskegee study and so forth. But I think one is there is a broad knowledge of these occurrences that have happened historically. So I think a lot of Black and brown people are aware of that, and that can lead to some mistrust. But I think also kind of organically, some Black and brown people recognize the disparity in the outcomes within the healthcare system and within access to certain like trials and interventions. And you know, if you looked at the numbers, you know, and you saw these poor outcomes, they are actually making reasonable choices, right? So if you look at the outcomes of Black and brown people in the hospital, and you say, well, if I go into the hospital, I am more likely to do worse, then the right thing to do is to not trust the system and not, and probably say, well, maybe I shouldn't do that, right? And so we need to, as Dr. Gaddy suggested, we need to establish that rapport, and we need to also make sure that we follow up and you know, and engender that trust in the system, so that they can actually know that coming to these institutions and enrolling on these trials will not result in poor outcomes or bias against them.
So having said that, which is very, I think, opens the doors for several avenues of discussion, but what do you think is the most important or most significant way that we can open up those lines of communication?
Well, that's an excellent question, Amy. I was watching this movie with my kids, and many of you on the call have probably seen it. It's called Shrek. And at one point in the movie, Shrek, who is an ogre, is walking through a meadow with the donkey, you know, his newfound friend. And he's trying to explain to the donkey kind of why he feels the way that he does. And he tells the donkey, well, ogres are like onions. I don't know if you guys remember that part of the movie. And so the donkey looks at him and he says, what do you mean? Do they smell stinky and make you cry? And he said, no, ogres are like onions because they have layers. And I think Black people, really all people, but Black people are like onions. We have layers. And I think one of the things that tends to happen is that people tend to focus more on the superficial layers, dark chocolate or milk chocolate covered layer, and not necessarily on the internal layers, right? And I think that's really where it needs to start, is really just having a conversation and really using good communication to get to know the deeper layers, right? Because at the end of the day, I think Black and brown people want the same thing that all people want, right? They want to be respected. They want to be cared for. They want to have the same access to opportunities that everybody else has, right? They're not asking for any special treatment. They really just want what is what everybody else has access to. And unfortunately, that is going to take a lot of change. It's going to be a multi-layer change. We have the will, I think, to change. And I think what you're kind of highlighting, Amy, is the fear of change. And so I think we have to acknowledge that and be brave and just kind of face it head on. Nowadays, you can't really build clinical trials excluding populations, right? So, for example, in the past, you could actually build a clinical trial excluding people who are, say, over 65. You can't do that anymore, but what you can do is that you can incorporate eligibility criteria that will weed out people who are over 65 by nature of them being more likely to have their more comorbidities, right? And so it's really the same thing, it's just kind of a different way of doing it. And I think to answer your question, breaking down those barriers will take multi-level interventions, like at policy levels. It will also take designing clinical trials that actually don't have these kind of strict eligibility criteria that are kind of more common in Black and Brown people, or exclusionary criteria, I should say. And then also getting clinical trials out in the community, right, where the actual people live, right? So Black and Brown people who are living miles and miles away, can't access these trials. They can't get to these major academic centers. They don't have the contacts that some of our more fortunate, patients have. So I think it will really require multi-level interventions to get at this.
Dr. Gaddy?
Of course. So ASCO put out, under the presidency of Dr. Lori Pierce, just last year, we published multiple podcasts really focusing on the social determinants of health. And I was fortunate enough to moderate a couple of those episodes. And I remember one of the first episodes, which was the importance of taking a social history. Medical school isn't that far off from my level of education. And I remember that being one of the parts where, okay, did you ask how many cigarettes did the patient smoke? How many years did they smoke? And do they drink alcohol? And if you ask those questions, you had like aced your social history. But as Dr. Jolly just alluded to, we are onions and we have so many layers. So there's much more layers to, did the patient smoke? Did the patient drink alcohol? How much? It's who's in the house with you? Do you feel safe in the house?
Right.
How did you get here today? Are you going to be able to actually get to your future appointments? Can you afford transportation? When I moderated that episode, one of the participants, Dr. Tucker Seeley, who does a lot of work on structural racism and health equity out in California, he said when he goes to his appointments for, his different doctor's appointments, he wears his Harvard alum t-shirt. And that's not to boast and say, oh my gosh, I went to Harvard, but it's to kind of make a statement that you are dealing with an educated Black man. So please treat me as such. But it really shows that oftentimes Black patients feel that they have to almost make some announcement or go out of their way to basically just receive that equal level of treatment that all patients should receive. So just going back to it, I think I try to always break some barrier when I meet my patient for the first time. If they come in with their spouse, I'm making sure the spouse feels included. How long have you been married? What keeps you guys married? Because when they come there, they know they're going to talk about their cancer. They know they're going to get an answer as far as what chemotherapy, when to start, what are the side effects, et cetera. But as a physician, I think it's really important for us to demonstrate that we care more about their actual overall well-being and those layers that Dr. Jolly referred to earlier.
Thinking back to the patient from our case study, Sam, we asked participants from our live webinar what disparities or barriers the patient is likely to face as he enters the healthcare system. Here is how they replied. As you can see, insurance coverage and financial strain rated the highest responses. This was followed by communication issues, transportation issues, lack of awareness of the significance of screening and follow-up.
So keeping in mind that this is a team discussion, we have to kind of look at Sam and see where his team needs to step in, even though he doesn't know he has a team yet, right? So Julia, question for you. What social determinants of health risk factors and barriers need to be addressed here for Sam and for many, many patients that we have?
Absolutely. The social determinants of health contribute hugely to healthcare disparities. And when we're talking about social determinants of health, we're talking about where people are born, where they live, where they work, how they do or do not access healthcare. And all of these are significantly impacted by structural racism. So when people don't have reliable access to healthcare due to transportation or because they can't get an appointment because they don't have the kind of insurances that make that possible or what have you, they're more likely to be diagnosed with later stage cancers, and that might have been treated more effectively earlier on if diagnosed at an earlier stage.
Right.
It's one of the reasons why North Carolina instituted the breast and cervical cancer screening program that tries to get as many women as possible in for screenings and promises them that if they are found to have one of these cancers, they're going to be able to get Medicaid and get the care that they need, even if they don't meet the other requirements for Medicaid. So it's a really great program. And it has led to increases in the screenings and early detections of those cancers to some extent. As social workers, we have the tools to screen people for those social determinant of health barriers and then provide assistance in applying to foundations, government programs, in-house programs within the hospital, healthcare system, and community resources. So we can really help navigate people through all of those. And some of the key risk factors that frequently arise in cancer care are things that Dr. Gaddy and Dr. Jolly were alluding to: transportation needs, housing insecurity, financial strain, possibly because they're going to be out of work while they're going through cancer treatment, but they may have already come into cancer treatment at a lower socioeconomic status, more of an essential worker versus the professional worker that has all these FMLA and disability benefits and so forth. And food insecurity is another one, and it's huge. And here at UNC, we've instituted the Food Well program. We're getting people grocery bags. We're at their clinic appointments. We're screening more for food insecurity. And it's phenomenal to me that we're giving tens and hundred thousands of dollars worth of cancer treatment to people, and you find out they don't have enough food in the house.
Right.
You know, it makes no sense, right? If you're not going to address that. And the food stamp program in the state is woefully inadequate. You've got people that are maybe getting $80, $120 a month. Well, that's not enough to eat. So these are the things that have to be addressed to make sure not only that they're getting everything they need that's going to support their treatment, but also that it's not being overlooked how difficult it's going to be for folks to just get here and to get the care that they deserve. And patients are often unaware of some of the community resources and the healthcare system resources. But I will always make a plug for the fact that there aren't enough resources. There need to be more. We also have the digital divide where patients, they don't have computers and printers and smartphones and Wi-Fi and all of that. And so they can't, we say, okay, we'll talk to you on my chart. It's like, well, they can't use my chart. Or we need to help them use my chart. We need to go the extra mile. And we're doing that more in the Patient Family Resource Center, sitting down with people, helping them sign up, helping them log in, because we know that's going to make their treatment and access better, because they're going to be able to send a message and they're going to be able to get a response back when they're having an urgent concern, and their healthcare experience is going to be better if they have access to those kind of modern technology tools. And the onus is on us to not just be like, oh, well, we have my chart. If you can't get it, that's your problem. No, the onus is on us to make sure we're helping people use it and get the access. And So those are, just critical pieces.
So and all of this directs us back to this concept of team communication, and it doesn't have to be this only the social worker does this, only the physician does this. It's that communication piece that it pulls everybody in, from social worker, navigation, pharmacy, provider, and all of those tendrils that can go out and kind of bring this back together. And it's not going to be an overnight thing. And just as we've discussed with the history of all of this, what do you think, Julia, when you have pushback from the patient who says, well, I don't have a smartphone, I can't afford a smartphone, my babies are going without diapers, et cetera, et cetera. So how do we break through that little barrier, which is not a little barrier, it's a huge barrier. And it's like almost the number one, right? So
yeah, I mean, I think the first thing that we have to do is we have to, the word isn't quite normalized, but we have to help them see that these are barriers that a lot of our patients are dealing with, and we're here to help.
right.
So making sure that people don't feel like it's a problem in them. This is a larger social problem. So I always make comments like, yeah, the resources aren't broad enough. We need to keep helping you get what you need. And I wish there was more. And I'm going to help you get everything you can because you deserve it. And I actually say that to people. You
Right.
deserve this.
Right.
And you'd be surprised at how many people are like, kind of like their eyes kind of open, like, wow, okay, she's really thinks I deserve this.
Right.
And it brings up one of the other issues, which is I'll have patients, and I know everyone here has experienced this, that will actually drop hints that they are afraid of discrimination because of their race, their language, their country of origin, their color, etc. And we cannot let those comments go by. We have to say, I hear you. And what you're saying is valid. Do you want to tell me more about that? Do you want to tell me about the time when you couldn't get an appointment because of this, that, or the other, or the time you got an appointment and you felt treated with disrespect?
Right.
Even if it was at our institution. We don't have to skip over that. It's important to acknowledge it. It's important to validate it and to say, I'm really sorry that happened. And I want to make sure that you feel heard and respected by us here. And if there's a problem with something, come to me and I'll try and help you get it resolved. And people really appreciate that, and it fosters trust. So I think that's an important piece.
I think it is too. And I also think that from a pharmacy perspective, Benyam, you probably see this a whole lot more than people realize. Is that a true statement?
Yes, for sure. I mean, we are involved in obviously patient education and ensuring that patients can start and maintain on their treatments and even afford their treatments. So this is something that we see. And a few points, and before I talk about the specific ways how our Black patients are impacted, I think it's really important again to just pause and realize that outside of our health systems, right, our patients are coming into our health systems already having interacted with systems that were not designed for them, right? So the educational system, the banking system, social welfare systems, all systems within the United States were not created for Black people, right? So I think when they are interacting with our healthcare system, and so one concept like health literacy, it really is known to impact the ability for patients to understand their medication instructions, their ability for them to advocate for themselves, and then navigating the complex specialty pharmacy process, which is often the case for a lot of our patients needing oral chemotherapy. But health literacy is important. We know that currently our Black population tends to be less well educated, but it's important to contextualize that. It's because there was a lot of exclusion of Black individuals from our education system. Insurance status, we know that private insured patients tend to do much better. There's actually a survival advantage to being insured than uninsured. And again, insurance is attached with employment, better employment access. We know that there's also racialized problem, right, with the hiring practices in various places. Cost of drugs, we know cost of cancer care is a significant barrier, even for insured patients. We know, like with Medicare Part D, for example, patients tend to face huge copays. A Kaiser Family Foundation study found that there's a Black-white disparity when it comes to Medicare Part D coverage. White individuals, half of white individuals tend to have employee-sponsored or supplemental insurance to cover excess copays when they have Medicare Part D, whereas only less than a quarter of Black patients have this type of coverage. So what that means is, like, a lot of these oral chemotherapy drugs tend to be around, $10,000 to $15,000 a month. Medicare Part D offers an 80/20, so you will be responsible for a $2,000 copay. So again, due to existing inequities, a lot of white individuals will tend to have supplemental insurance or be able to have other private insurance to cover that $2,000, that 20%, whereas a lot of our Black patients will not. So this is where we see a lot of the gaps in care. And so I'm oftentimes working closely with our medication access technicians or with our social workers to try to help fill this gap to make sure our patients are able to stay, on therapy. And the other piece is really with symptom management. So a lot of our patients will have side effects from their treatment, and we know that there are lots of data about how when Black patients present with side effects, they are not believed. There was a study with medical students showing that they actually, a portion of medical students believed that Black patients tend to tolerate pain at a higher rate than white patients. There was a study by the Eastern Cooperative Oncology Group that found 74% of Hispanic patients and 59% of Black patients received suboptimal treatment for pain. I have published my own experience with a family friend who was presented to the emergency department of Black women with pain, turned away for 6 months before she was finally diagnosed with rhabdomyosarcoma and passed away. And so this is well documented, right? So we need to also recognize within ourselves that there may be a component of implicit bias, and I think anyone who says that they're not biased, I mean, we all have some level of bias. If you're a human, you have some level of bias. I think it's recognizing that and then being able to try to correct that actively is really important when we're be interacting with our Black patients and considering their different requests or questions.
So the importance of this conversation is just that. This is a team that is sitting here having this discussion. It needs to be incorporated into facilities and into physician training, nurse training, pharmacy training. Needs to be considered a team. This is a team effort. What about Sam? What do we do about Sam?
We got to get him here,
Mm-hmm.
And he's facing all of these barriers that are making that difficult. So it's on us to actually reach out to him. Healthcare is a reactive system, not a proactive system. So it's like, well, if he's not here, he's not here. On to the next one. But no, this is where we have to make the extra effort. And I know this is a case where the team would pull me and say, hey, can you call this guy and see what can we do to help get him here? And that would be, in my mind, the first step. And I'm social work is a great role to do that. And to call and introduce myself and say, hey, we know that the team really wants to get you in. And your primary care provider really wants you to come and have these things checked out. And tell me a little bit about you, about your family, about, build some rapport. what kind of work are you doing? I mean, we're privy to this information in the case study, but we might not know all this stuff yet, and we want to build rapport. So we're asking and we're saying, is there something I can do to help your boss? We can write a letter so that your boss knows you're coming for an appointment, so that it doesn't look like an excuse. And how else can I help you get here initially? Once they're here, then I think the team really kicks in, and I'll hand it over to Dr. Jolly and Dr. Gaddy and Benyam, and what would you all do to try and engage him in addition to looping me back in with resources for him and so forth?
So I'll just say that I think one of the points that Benyam brought up is really important, is key, and I hope it was heard and received. So I think we need to check our biases, right? All of us, right? So I'll give you an example of what I mean. I was on a plane yesterday. The guy who was sitting next to me was Black. Started having a conversation with him under the assumption that everybody goes on the plane all the time. And at the end of the conversation, he looked at me and he said, "This is the first time I've been on a plane." And I let my guard down, because I usually do that in clinic. You know, I kind of get to know people when I'm in the clinic, right? I try to get a sense of where they are. But on the plane, I was totally out of my element. And so I think we need to not assume anything about anybody, right? And we just need to get to know people, get to know the layers, right? Peel back those layers of the onion. The chocolate colored wrapping paper is not it. There's a lot deeper feelings, emotions, thoughts that I think Black people have. And at the end of the day, you know, as I said, all they want is what everybody wants. We're just humans. We're just humans, and we want the same thing that everybody wants. And so just think of the golden rule. What would you want if you were that patient sitting there? You probably would want the same thing, and Black people want nothing different.
Correct. So I wanted, Dr. Gaddy, do you have something to add?
Sure. I think Dr. Jolly just hit it right on the head. He said that we're humans as well. Mr. Whitfield, one of the children of one of the victims from Buffalo 10, he said, we just want to be treated like humans.
Right.
And I think you, Julia, you said earlier, asking the patient, how can we help? Because sometimes the patient has a great idea, like, if only I had this one resource, I think I could kind of figure out everything else. And then lastly, also commending the patient for being so vulnerable.
Yes.
You know, patients are so scared or they're embarrassed. I don't want my provider to think about me differently. So really commending them for being so honest about where they are and what they're struggling with.
How do racial disparities in treatment impact the management of side effects?
Yeah, sure. I think one thing I've seen, and again, this is across the board, but more commonly in minoritized individuals, is a reluctance to bring up side effects, because fearing that either you won't be believed or that you will get less optimal care, right? So we talked earlier about the awareness of the historical injustices that have been passed down from generations. So when individuals come to our healthcare systems, they're aware of that, and so they are reluctant. So I think that it's really important to proactively ask. So we have like a protocol where we ask specifically about different common side effects that patient might have, even when they're not reporting. We were like, do you have any nausea? Or do you have any pain? Do you have any, common side effects that we know? Because sometimes the patients may say, nothing is bothering me, but when you ask them, are you experiencing these side effects? Because we can help you. You don't have to suffer through this. They're more willing to talk about their side effects.
I'll just add to that one, even before we get to that point. You asked the question earlier about clinical trials. So there is no surprise to me that people of color, Black people in particular, we often see some of these toxicities that we don't see reported in the trials. And that is exactly for the reason that I alluded to earlier, that they were not in the trial. And so you're uncovering some effects that have not been seen because the drugs have not been studied adequately in that patient population. The same thing happens for the disparities in the patient population that I work with, older adults. If they're not included in the trials, then you find out about the toxicities. You just don't find out about it now. You find out about it later
early on, we talked about the fact that communication was key to all of this. And it's great just a reminder that it's great to have that communication with the patient. But if we're talking about a team approach, we have to be able to communicate with our team members as well. So I think one direct way that we can encourage patients to trust us is to be honest with them and give them the information that they really need, not sugarcoating, not saying that life is just not in it here. There's something out there that we can do to help in each and every situation, right? So from the person who takes the information on the phone to get the patient in, needs to have some excellent communication skills and a desire to really help this patient to get to the first point, which is to see us, right? So
I'll just add briefly to that, if I have a minute, to speak to the patient, not at the patient.
Not at the patient.
Correct.
That is
correct.
Because
I think it happens a lot. And so to your point on the communication, where we use a lot of med speak.
Mm-hmm.
And a lot of our patients, again, checking your biases, you grew up, you're educated, all of you went to med school. And it happens a lot with the residents and the interns and our trainees that they just start talking about, well, the receptor this and the receptor is that. And the patient is just looking at you glazed over, and they'll never tell you.
What is this? Right.
Exactly. They'll never tell you because they don't want to feel embarrassed, right? And so you
Right.
really need to, you need to talk to the patient and not at the patient.
At the patient.
So when we're thinking about as a multidisciplinary team, with all of us as the different actors in this team and the best strategies for our patients, there are some key strategies that we can utilize when we are talking about changing the culture and changing how we view our patients and in their needs in closing this gap for some disparities. For an example, as a nurse navigator, what can I do myself to close this gap just a little bit? Be comfortable with your own skin and then step into somebody else's. So that would be followed by another step, and that would be, as a navigator, getting with your navigator cohorts and discussing this, bringing this up, talking about it, not hiding it, not addressing it piecemeal, but addressing it as a whole new picture for how you're going to approach and close this gap for disparity. Dr. Gaddy, what would be your key strategies?
Key strategies that I would recommend is first thinking about actually what you just said. So being aware of one's own privileges and internal biases, and determine how those biases and privileges can actually impact equitable care delivery. Additionally, taking the time to really understand the social determinants of health of your patient, as opposed to only focusing on their cancer needs. This strategy would likely contribute to improving the rapport that you have with the patient, and then allowing them to feel more at ease and a higher level of comfort with reporting new toxicities or other cancer-related challenges. So I think those are some of the strategies that I would recommend for implementation.
I just feel so strongly that until those barriers are broken down, you're not going to ever really be able to reach that patient. Because the whole thing, how we approach cancer care in general, is that while some of these things might be the same thing, to the individual person, they are not. And you've got to get down to the bottom line of what makes the care for that person be the best kind of care that we can possibly come up with. So, Dr. Muluneh, have you got some key strategies you'd like to throw in?
Yeah, I think that as Dr. Gaddy and you mentioned, Amy, you can really think about this in two categories. There's the interpersonal, and then there's the infrastructure piece.
Yes.
So from the interpersonal, I think that we have to work as individuals in being more trustworthy and trying to build that trust between our patients and the clinicians. That, one example is proactively asking our patients open-ended questions. So instead of what symptoms have you been experiencing? What symptoms are bothering you today? So asking that instead of, are you feeling okay? Or are you having any side effects? Those kind of closed-ended questions. So keeping things open, and not just on the clinical concerns, but also on the financial concerns can help build trust. On the infrastructure side, I think once we've asked those questions, we have to be ready to deliver answers. So we have to have systems and processes in place to support patients. And so our institutions should have a systematic approach to addressing clinical and financial concerns. I think that, pharmacists, nurses, and other allied health professionals can be great partners to our physician colleagues who are extremely busy, as well as our social work, our, financial counseling and medication access technicians from a financial and other psychosocial areas, which I know will be discussed later.
Julia, do you have something to add in the social working realm?
I do. Tagging on to what you were saying, Benyam, about processes in place, I think it's really important that institutionally we are screening for the social determinants of health to find out about people's concerns about not having enough food, not having transportation, unstable housing, financial strain and toxicity. And tagging on to what Dr. Gaddy said about building rapport and getting to know people as a whole person. Anytime I sit down with the person, I'm asking them about them and their life. Tell me about you, tell me about your family, tell me about who you brought with you today, who's at home, who's working in the household, who's missing work, who are your supports, emotional supports, spiritual supports, practical supports. Can we enhance that for you? Can we help you expand that? Really helping people know that we care about them as a whole person. I felt like one way that I could intervene was to be an advocate for them and go to the team and say, listen, I think we need to get at what this person is needing, even if the way it got presented to us was challenging. Let's get in there and let's keep trying to help them. And I found that was really important to making sure that they got equitable care. And after having a couple of those experiences, it empowered me to want to do more of that.
Remembering that there is a whole community of people who are willing to help and willing to help close the gap. So don't be afraid to find out what it is, who can also take ownership of some of this. And if we work well together, then, and we're all on the same page, that is all the better for closing that gap. So Dr. Jolly, what do you have to add to our pocket full of good things?
I think I'm really just want to highlight many of the things that you all have already said. When we think about disparities in healthcare, the focus tends to be on certain aspects of those disparities, and we have this concept where we try to find kind of the one thing that causes an underlying problem. So what is causing the patient's problem? And that is historically how we have been trained, to look for the one thing that's contributing to a presenting complaint. But we were learning more and more that there is not one thing, particularly in the patient population that I tend to care for, older adults with cancer. It's usually more than one thing. It's multiple things all coming together to cause or to contribute to a certain problem. So it's kind of like the straw that breaks the camel's back, keep adding, and then eventually it kind of all comes down. And so I think that these disparities have multiple causes, and we need to address it with kind of multi-pronged interventions, many of which you guys have mentioned. I think there are kind of several broad levels at which this needs to be addressed. So we've talked about kind of at the patient level. It has to be addressed at the provider level, system level. I think many of you have touched on that. And then even above that, higher up, kind of at the policy, national policy level, I think you guys have talked about how we address the need for resources with things like patient navigation, just kind of getting a sense, Julia, you touched on this, of what it's key. Dr. Gaddy mentioned acknowledging our privileges and dealing with our biases. Those are key strategies to reduce these disparities. And then at the system level, I think, Benyam, you mentioned the resources that were available for patients, simple things like parking, transportation, financial assistance, social support, just the way that the clinic is designed. One of our providers mentioned that walking into a space where you see pictures of people on the walls that none of them look like you can sometimes be threatening to people of color, right? So just simple things like how we design the buildings. And then finally, at the policy level, there are certain things that disproportionately affect or impact underrepresented or minoritized populations, lack of access to insurance or Medicaid expansions, those kind of things. And those are kind of higher up policy discussions that need to be addressed. So it's appropriate that we're talking about cancer, because when we hear the word cancer, we think of kind of the multi-pronged tumor that's kind of affecting our patients. Well, I think of the disparities as kind of like that, right? That there are multiple aspects that need to be addressed at various levels. And the key takeaway for our presentation today is just to acknowledge that and to try our best to address each aspect and not just focus on one or the other.
Probably one of the most appropriate ways to gather all of that up is just to remember that it is going to take a lot of people on a lot of team levels, from yourself all the way up the ladder to the really big people up there that make all these decisions on how we're going to move forward. It's opening the eyes, opening the communication. But if you remember that this is patient-centered, I think all of these are really wonderful strategies. And I think that starting with the conversation.
I just want to say thank you again to my panelists. You all are wonderful providers. I've said this before, but I'll say it publicly. You're my dream team. So thank you very much. Thank you.